Welcome! We're about to simulate a general surgery consultant viva, one of those high-stakes oral exams. We're going to tackle two classic anorectal cases. I'll be playing both the examiner and the candidate so you can see the ideal way to think through these problems. Let's get started.
Good morning, doctor. Please have a seat. We're just going to run through a couple of clinical cases. I want you to talk me through your thought process, just as if you were the consultant on call. No need to waste time. Are you ready?
Okay, let's start with a pretty common presentation you'd see in your clinic. Thank you. Okay, based on that classic history, the first thing that jumps to my mind is an anal fissure. That triad, the severe tearing pain with bowel movements and the bright red blood on the paper is almost pathognomonic. Sure, you might think of a thrombosed hemorrhoid, but the pain's specific timing with defecation really pushes me toward a fissure. Less likely things could be proctalgia fugax, maybe a solitary rectal ulcer, but a fissure is number one on my list.
So, to really nail down the diagnosis, I need a more detailed history. And then I would move on to a very, very gentle physical exam.
Right, so an anal fissure is just a tear in the anoderm, distal to the dentate line. The real problem, and the source of that intense pain, is the spasm of the internal anal sphincter underneath it. That spasm cranks down, cuts off the blood flow, and stops the tear from healing. This is why the history is so important. I'd ask about constipation, straining, because patients get so scared of the pain, they start avoiding going to the bathroom. This makes their stool harder, which then makes the fissure worse. It's a classic vicious cycle.
And how would you tell the difference between an acute and a chronic fissure? Well, the main distinction is simply time. If the symptoms have been there for less than, say, 6 to 8 weeks, we call it acute. On exam, it just looks like a fresh, superficial cut. But a chronic fissure, that's different. It's been there a while, and the body has tried to react, so you start seeing these secondary changes. You'll see some fibrosis at the base of the tear, a little sentinel skin tag on the outside, and a hypertrophied anal papilla on the inside.
Okay, on examination, you find the fissure is located laterally. It's not in the midline. What's the significance of that finding?
That's a huge red flag. A lateral fissure is not your typical finding at all. The vast majority, something like 90%, are in the posterior midline, probably because of a little less blood supply there. So when you see one that's off to the side, you absolutely have to think about an underlying systemic disease. My alarm bells are ringing for things like Crohn's disease, maybe a malignancy, TB, or even an STI like syphilis or HIV. That finding means we need to do a much bigger workup.
Good. Let's say it's a typical acute posterior midline fissure. How are you going to manage it initially?
For a straightforward acute fissure, we start conservatively. The whole idea is to break that cycle of pain and constipation. So, first, stool softeners and a high-fiber diet. We need those stools to be soft and easy to pass. Then, I'd recommend warm sitz baths a few times a day for symptomatic relief. You could add a topical analgesic too. It's a simple plan, but it works for about half of these patients.
All right, so the patient comes back after 8 weeks, they've failed that conservative therapy, and now we're calling this a chronic fissure. What are your non-surgical options at this point?
Right, so with a chronic fissure, the problem is that overactive internal sphincter. So the goal of our medical therapy is to relax it. We call it a chemical sphincterotomy. My first choice would be a topical calcium channel blocker, like nifedipine or diltiazem cream. They work well and tend to have fewer side effects like headaches than topical GTN. Another really good option is injecting botulinum toxin, Botox, right into the internal sphincter to paralyze it temporarily.
Medical therapy has also failed. What is the gold standard surgical treatment and how well does it work?
Okay, so at this point, we've exhausted our non-operative options, and we have to move on to the definitive surgical plan.
The gold standard, without a doubt, is the lateral internal sphincterotomy, or LIS. It's a pretty straightforward procedure where we make a small, controlled cut in the internal anal sphincter muscle. By doing this, we permanently lower the resting pressure in the anal canal. That relieves the spasm, brings back the blood flow, and finally lets that fissure heal.
And the reason we call it the gold standard is simple. It works. The long-term healing rate after a properly performed LIS is over 90%. I mean, that's incredibly effective, and it makes it the best treatment we have for this stubborn problem. Recurrence is very rare.
And what is the most significant complication you have to counsel the patient about before you do an LAS?
The big one, the one we absolutely have to discuss in detail, is the risk of incontinence. Usually it's minor, like trouble controlling gas, but it's a real risk. So to minimize that risk, the modern technique isn't to just cut the whole muscle. Instead, we do a tailored sphincterotomy. We only divide the muscle up to the top of the fissure itself. And for patients who are at high risk already, say a woman who's had multiple childbirths, I'd seriously consider a different procedure altogether, like a fissurectomy with an advancement flap, which doesn't involve cutting the sphincter at all. Excellent. Let's switch gears. New scenario. A 45-year-old man comes into the emergency department. He's had 48 hours of severe, constant anal pain. There's a palpable, tender swelling, and he has a fever. What are you thinking now?
Okay, totally different picture. This presentation just screams anal rectal abscess. The pain is constant, not necessarily tied to bowel movements, and he's got systemic signs like a fever. This all points to infection. The whole process starts in these tiny anal glands, the crypts of Margani, right at the dentate line. One of those gets blocked, bacteria get trapped, and boom, you get an abscess.
And from that blocked gland, the infection can track into a number of different spaces around the rectum. Where it goes determines what you find on exam. If it's a perianal abscess, you'll see a tender red lump right at the anal verge. An ischiorectal abscess, like you see here, is deeper. It causes a big, painful, swollen buttock. And the intersphincteric ones, those are tough. There's not much to see on the outside, just deep, severe rectal pain. Supralevator abscesses are even sneakier.
What's the definitive management? Unequivocal. The definitive and urgent management is surgical drainage. Antibiotics by themselves won't cut it. You have to get the pus out. For a simple perianal one, you might be able to do it under local, but for anything deeper, that patient needs to go to the operating room for an exam under anesthesia. The key is to make a big enough incision to let it drain, break up any pockets of pus inside, and wash it out thoroughly.
And do all these patients need antibiotics after their operation? No, actually. For a healthy person with a simple abscess, once you've drained it, you're done. But there are specific times when I would add antibiotics. If there's a huge area of cellulitis around the abscess, if the patient is septic, or if they're immunocompromised, diabetic or on steroids. Also in patients with things like prosthetic heart valves. In those cases, yes, they get antibiotics. Afterwards, it's all about sitz baths and letting the wound heal from the bottom up.
Okay, last red flag. A diabetic patient comes in with rapidly worsening, severe anorectal pain. The pain seems way out of proportion to what you're finding on your exam. What life-threatening diagnosis must you consider? This is the one we absolutely cannot miss. Pain out of proportion to the exam, especially in a diabetic, is the textbook presentation of a necrotizing soft tissue infection, like Fournier's gangrene. This is a 5-alarm surgical emergency. My threshold to take this patient to the OR would be incredibly low. They need immediate, aggressive surgical debridement of all the dead tissue, plus heavy-duty antibiotics and full-on ICU support. Any delay here is catastrophic.
Very good. You've correctly identified and managed two very common and very critical anorectal conditions.
What we've just gone through really demonstrates that consultant-level thinking. It's all about having a structured plan. You start with your differential, use the history and exam to narrow it down, and you know the indications, the steps, and, crucially, the complications for every treatment you propose. You have to be logical, and you have to be ready to act fast when you see those red flags.
So, let's end with one last question that really ties these two topics together. You've just drained a big ischiorectal abscess. What are the chances that this patient will go on to develop a fistula? And how do you talk to them about this possibility after the surgery? That's a critical part of your follow-up care. That concludes our session. Thank you, doctor.